Welcome back to the Deep Dive. Today we are strapping in for what might be one of our most critical deep dives yet. We're talking about the human body's silent language, specifically the really detailed diagnostic signals the skin sends us. This material we've compiled is just a fascinating stack of high-stakes medical patterns, the kind of knowledge that truly separates a routine assessment from a critical, life-altering intervention.
That's absolutely right. Our mission today is, well, it's laser-focused on pattern recognition. We're moving past the general knowledge and really zeroing in on specific, often subtle clues. Clues that differentiate, say, a benign condition, one that just needs reassurance from a life-threatening systemic disease.
And worse.
Or, in the most severe cases, the signs of intentional harm, sadly. We're not just reading the textbook here. We're trying to extract what our sources call the high-yield points and those crucial explanation pearls, things that give you an immediate diagnostic shortcut.
Okay, let's unpack this then. We have an incredibly broad and deep field focus today. I mean, covering everything from the most common, benign neonatal rashes, the kind you just reassure parents about,
Right.
all the way to chronic liver disease showing up on the hands, and the absolute crucial physical signs of child abuse. We are going to use specific details from these sources, like certain burn patterns or, rash distributions, to quickly become well-informed on these vital diagnostic shortcuts. This is the kind of information that turns simple observation into immediate, necessary action.
Exactly. Observation leading to action.
We have to start with the highest stakes pattern recognition available, I think, the area where observation can literally protect a life. So Section 1 deals with identifying patterns that signal intentional harm, and we're looking specifically at deliberate scald burns. What we learn from the sources is that the location and the shape of that burn, that's the key evidence. It often trumps any story the caregiver gives.
Yes, this is a profoundly difficult but absolutely necessary topic to analyze clinically. Inflicted scald burns, they're almost always caused by the forced immersion of a child into hot water, a scenario tragically, almost invariably linked to child abuse.
Right.
And when this happens, the child's natural immediate reflex is to pull away to protect themselves. This leads to forced muscular flexion, bending tight at the ankles, the knees, and the hips.
Okay. So the child's desperate attempt to escape the heat is what actually creates the diagnostic map for us. What does that forced posture do to the physical appearance of the injury?
It creates the crucial diagnostic hallmark. Because of that forced, tight flexion, the very hottest water just cannot physically reach into those tight skin creases.
The folds of skin.
Exactly. This leads to the sparing of flexural creases, specifically in the groin, maybe the armpits, or behind the knees and ankles. Our sources highlight this sparing, where the skin folds remain pristine, white, almost untouched, while the surrounding skin is severely burned, as a highly specific sign of deliberate immersion. It's that visual inconsistency that flags the intentional nature of the trauma immediately.
I see. So the burn itself is often on the buttocks, the back, or the legs, the parts of the body forcibly held under the water, but the areas that are naturally folded and protected by the child's own, forced posture are completely clear. That's really counterintuitive if the story is the child simply fell into a tub.
Precisely. It doesn't match that story. Furthermore, we look for other signature features that define this as intentional, related to the mechanics of forced placement. The burns exhibit a sharp demarcation. There's a clear, definitive line, almost like a watermark, where the water ended.
Like a tide line.
Exactly, a tide line. The depth of the burn is often uniform across the entire affected area, which is also unusual for a spill. And visually, you might see a classic stocking glove distribution on the arms or legs, where only the submerged part is burned, ending abruptly.
And the absence of one specific type of feature is just as important, you mentioned, as the presence of those spared creases.
Absolutely critical. Crucially, in contrast to what happens accidentally, there is a distinct absence of splash marks.
Right.
When a child falls or accidentally spills hot liquid, there's splashing, there's momentum, drips running down. A forced immediate immersion prevents this chaos. The absence of those uneven splash or drip marks strongly reinforces the suspicion of abuse.
That distinction is incredibly powerful visually. So let's quickly contrast that with the evidence the sources say represents an accidental injury. An accidental spill tells a very different story visually.
It really does. Accidental spills typically result in asymmetrical distribution. The liquid runs, it pools unevenly, it follows gravity.
Makes sense.
Because the liquid runs over the skin, the depth of the burn is non-uniform. It varies from superficial to deep in different areas depending on how long the contact was. You see poor demarcation of the wound margins, no sharp lines, and overwhelmingly you must find the presence of splash marks where the hot liquid first hit the skin and then ran down.
So if a caregiver reports an accidental spill, maybe from a cup or pot, but you see those sharp margins, maybe that stocking glove pattern, and especially those protected, spared creases.
Then the history is inconsistent with the clinical picture. The story doesn't fit the physical evidence.
In this kind of high-stakes situation, the action is immediate and mandatory once that clinical suspicion is raised. There's no waiting.
No, it relies entirely on recognizing that pattern inconsistency. Once the suspicion is raised based on these very specific burn patterns, the mandatory step required in most places is immediate reporting to Child Protective Services. You stabilize the patient medically, of course, treat the burn, but the priority must be recognizing the specific high-yield pattern to protect that child from any further harm.
The skin, in this case, is truly the silent witness.
It really is.
Okay, that was a heavy but absolutely necessary segment. Let's transition now from that high-stakes intentional harm to, well, still high-stakes differential diagnosis, but more in the realm of pediatrics and environmental clues. We're moving into the micro-world of rashes and pests.
Right, and we need to start with one of the most common, yet often anxiety-inducing benign rashes in newborns. We're talking about erythema toxicum neonatorum, or ETN.
ETN, okay.
We introduce this really as the ultimate benign contrast point, something that looks alarming to new parents but requires absolutely no intervention. It's a self-limited rash that just pops up in the first, say, 3 days of life. It's thought to be maybe an innate immune response, reacting harmlessly to normal skin bacteria penetrating the hair follicles.
So how do we reassure the nervous parent who sees this? What are the key features we look for in ETN? What makes it distinctive?
Well, it usually starts as erythematous macules, just flat red spots or papules, which are small raised bumps. Then these progress rapidly into yellowish-white pustules, little bumps containing pus, sitting on a distinct red base, so it looks quite inflamed.
Sounds dramatic.
It does. But the key distribution is the trunk, and the proximal extremities, the upper arms, upper legs. But here is the critical high-yield point about location that serves as our shortcut. ETN absolutely spares the palms and soles. Ah, okay. So if the baby looks well otherwise, is feeding okay, doesn't have a fever, and the hands and feet are completely clear, then we can probably breathe a sigh of relief.
Exactly. The infant is otherwise totally well, and the rash just disappears on its own within about a week.
Yeah.
And this distinction is everything, because serious infectious rashes, things like congenital syphilis or neonatal herpes simplex virus, HSV, which do require immediate aggressive intervention, they almost always involve the palms and soles.
Right.
And they usually present with other signs of systemic illness like fever, poor feeding, or lethargy. So if the baby is systemically well and the hands and feet are clear, it's ETN, management, simple reassurance only.
That's a really powerful and practical differential for anyone seeing newborns. Okay, now let's pivot from internal physiology to external pests. Let's talk about a sign that's universally memorable, the breakfast, lunch, dinner sign.
Ha! Yes. That phrase instantly points us toward bedbug bites. Bedbugs are these charming nocturnal parasites that feed at night on exposed skin.
When they bite, they inject salivary proteins that do two things. They inhibit coagulation, keep the blood flowing so they can feed, and they trigger a local inflammatory response, which leads to the reaction we see. The lesions are typically intensely pruritic, very itchy, erythematous papules, often clustered together, and sometimes you can even see a tiny central hemorrhagic punctum where they actually fed.
And the key pattern is that linear or clustered arrangement, the classic breakfast, lunch, dinner trio. What does that pattern actually represent? Why in a line?
It likely reflects the bug's feeding strategy, or maybe its inefficiency. They don't always hit a good capillary on the first try, or perhaps they get disturbed slightly while feeding, so they typically move just a short distance along the skin and bite again, maybe probing. This creates that characteristic linear pattern, often 3 to 5 bites grouped together in a row.
And where do we usually see these bites?
On exposed areas, places not covered by pajamas, like the neck, the arms, the face, the torso. And since they live in the environment, mattresses, box springs, furniture crevices, even behind wallpaper, it frequently affects multiple household members at the same time. That's another clue.
The management here sounds tricky because it isn't just treating the skin reaction, it's treating the whole environment, and they sound incredibly hardy.
Oh, they are extremely challenging to get rid of. While supportive care for the itch is necessary, topical corticosteroids or oral antihistamines can help with that. The definitive treatment is environmental eradication. And bed bugs, unlike many other pests, are incredibly resilient. Our sources note they can survive up to 1 year without feeding by entering a state of sort of suspended animation called diapause.
A year without eating.
Yeah.
Wow. That explains why just, vacuuming or standard cleaning isn't nearly enough.
Not even close. It requires extreme measures, really. High heat laundry washing and drying above 60 degrees Celsius or 140 Fahrenheit is essential for all bedding and clothes. And freezing contaminated items that can't be washed, like books or electronics, below minus 18 Celsius or 0 Fahrenheit for several days is often necessary to break their life cycle. You have to treat the habitat aggressively, not just the person.
Got it. And just to briefly clear the differential for our listener, this breakfast, lunch, dinner pattern is not chiggers, right? Those are outdoor related. They attach for days.
Correct. Chiggers are mites from grassy areas they embed. And it's not scabies either. Scabies involves those telltale burrows, usually in the web spaces between the fingers, wrists, elbows, and it causes this intense, relentless itch, often worse at night.
Okay.
Bedbugs are distinct because of that environmental clustering, multiple people affected, bites in the house, and that specific linear bite pattern on exposed skin. The location of the habitat and the line of bites are the defining differentiators.
Understood. Okay, finally, in this pediatric section, we have the ubiquitous diaper dilemma. This comes up all the time. How do we quickly and reliably distinguish between simple irritant contact dermatitis and a stubborn yeast infection, like Candida? Because the treatment is fundamentally different.
Yeah, this is a classic. And the entire distinction really boils down to one simple observation: looking closely at the skin folds.
The creases?
Exactly. Irritant contact diaper dermatitis is the most common type. It's basically caused by skin breakdown from prolonged exposure to moisture urine, feces plus the enzymes in stool and urine, and simple friction from the diaper rubbing. It's essentially a chemical burn combined with friction irritation.
So the rash itself reflects that direct physical and chemical contact only in the areas where the diaper actually touches the skin.
Precisely. The key pattern is that the rash is limited strictly to the diaper contact area. So the convex surfaces, the round parts of the buttocks, the inner thighs, the lower abdomen. And crucially, it spares the skin folds, the deep inguinal creases, the gluteal cleft. Those deep creases are naturally protected from the constant friction and moisture, and often barrier ointments collect there, offering more protection.
What does it look like?
This rash is generally a duller red, maybe a bit shiny or eroded, but it lacks those distinct satellite lesions we'll talk about next.
Okay, so if the folds are clear, nice and pale, we treat with barrier protection. Simple enough. But the moment we see involvement in the folds, we have to think differently. We have to consider Candida albicans.
That's the critical pivot point. Candidal diaper dermatitis, which is a yeast infection, often comes in after the initial irritant breakdown has already compromised the skin barrier. The yeast takes advantage.
Makes sense.
This rash is typically described as beefy red, very bright red, confluent, meaning it's all sort of run together. And most importantly, it involves the skin folds. Candida absolutely loves the warm, dark, moist environment provided by those creases.
Especially if the baby's been on antibiotics, maybe.
Oh yes, that's a common trigger.
Yeah.
Antibiotics knock out the normal competing bacteria on the skin, allowing the yeast to overgrow.
And how do we identify the classic extension of the yeast, the sign that really clinches it?
We look for the telltale satellite lesions. These are discrete, small red papules and sometimes pustules that appear outside the main confluent rash boundary. They look like little islands or outposts scattered around the main beefy red continent of the rash.
Ah, the satellites. Okay.
The involvement of the folds, plus the presence of satellite lesions, that is the definitive diagnostic combination for Candida diaper dermatitis. If you see those signs, a simple barrier cream like zinc oxide won't cut it. It might even make it worse by trapping moisture.
So that's the treatment then.
You need to move directly to a topical antifungal cream like nystatin or clotrimazole to manage the yeast overgrowth directly. It's a perfect example of how subtle pattern changes folds involved versus folds spared, satellites present versus absent dictate a completely different targeted treatment plan.
That structural logic, folds spared versus folds involved, is immensely helpful. Okay, let's transition now to chronic conditions. We're moving beyond the surface issues and into section 3. Systemic signals. The skin often acts as the first warning system for issues deep inside, particularly with the liver or the overall metabolic system.
Yes, and a classic, really high-yield connection that every informed learner should know is the link between chronic hepatitis C, HCV infection, and a specific skin condition called porphyria cutanea tarda, or PCT.
PCT, okay, what is that exactly?
PCT is fundamentally a photosensitive skin disorder. It results from an inherited or, more commonly, an acquired impairment in porphyrin metabolism. Specifically, there's a problem with an enzyme called uroporphyrinogen decarboxylase, or UOD.
So the body can't properly process these metabolic compounds, these porphyrins, and when they build up and reach the skin, they react violently to light, specifically UV light. What are the clinical features we actually see on the patient?
The features are quite distinct and often striking. Patients develop very fragile skin, leading to vesicles, small blisters, and bullae, which are larger blisters. They also get erosions, scarring, and sometimes these tiny white bumps called milia. And the key location is specific. It happens almost exclusively on sun-exposed hands and forearms. They might also notice extreme skin fragility, where even minor bumps or scrapes cause the skin to literally shear off.
Wow, okay. So this presentation, blistering, fragility, scarring, specifically on sun-exposed skin, especially the hands, that's the signal. What is the powerful diagnostic pearl here that links it directly to a serious internal condition?
The diagnostic pearl, the big takeaway, is that this specific presentation strongly signals an association with chronic HCV infection. While PCT can be triggered by other things like alcohol abuse, estrogen use, or iron overload, hepatitis C is a major cofactor. In fact, it's often present in over 80% of North American patients who develop PCT.
80%, that's huge.
It is. So if a patient presents with these characteristic hand lesions, the mandatory next step is screening for HCV. That means ordering both an anti-HCV IgG antibody screen and, if that's positive, an HCV RNA PCR test to confirm there's active viral replication.
So the skin is essentially giving us an urgent clue about a potentially silent chronic viral infection damaging the liver.
Exactly. The skin is sounding the alarm.
It's really fascinating how far-reaching Hep C can be, beyond just the liver damage itself. We tend to think of it primarily as, well, hepatitis liver inflammation, but it clearly has massive extrahepatic implications.
Absolutely. HCV is fundamentally a systemic problem that often masquerades simply as a liver problem. It's strongly associated with several severe extrahepatic manifestations. For instance, cryoglobulinemia. This is an inflammatory condition caused by abnormal circulating antibodies, cryoglobulins, that clump together in cold temperatures. This clumping can block small blood vessels and lead to vasculitis, inflammation of blood vessels, causing rashes, joint pain, nerve damage.
Okay.
We also see membranoproliferative glomerulonephritis, which is a specific type of kidney disorder where immune complexes deposit in the kidneys, causing inflammation and damage to the filtering units.
So the blistering skin is really just one visible facet of this deep systemic inflammation being driven by the chronic virus.
That's a great way to put it. It's the tip of the iceberg, often.
That provides critical context. Management then isn't just about putting creams on the blisters, it's about treating the root cause, the virus itself.
Correct. Management absolutely requires treating the underlying HCV with modern direct-acting antiviral medications. These drugs are highly effective and often lead to complete resolution of the PCT as the viral load drops. Alongside that, we also treat the PCT symptoms directly, often with serial phlebotomy basically, drawing blood regularly to lower the body's iron stores and reduce porphyrin levels. Sometimes low-dose hydroxychloroquine is used carefully as well.
But the main lesson is, the skin diagnosis absolutely necessitates a viral investigation.
Without question.
Okay, let's move to another major systemic signal the skin gives us. The unmistakable velvety appearance of acanthocyst nigricans, or AN.
Ah, yes, AN. This is defined by hyperpigmented, meaning darkened velvety hyperkeratotic plaques. Hyperkeratotic means thickened skin. These plaques are typically found in the major folds of the body, classically the back and sides of the neck, the axillae, the armpits, or the groin. It's not just a color change. It's an unmistakable, almost leathery or velvety texture and thickening you can feel.
What's the underlying molecular engine driving that specific, palpable skin proliferation? What's making the skin thicken like that?
The primary cause, especially for the benign form we see most often, is insulin resistance.
Okay.
When the body's cells become resistant to the effects of insulin, the pancreas compensates by producing much more insulin to try and manage blood sugar. These resulting elevated levels of circulating insulin, and also related insulin-like growth factors, IGF, then act directly on the epidermis, the outer layer of skin. Insulin itself is a growth factor, and when present in high concentrations, it drives the proliferation of keratinocytes, the main skin cells, leading to that characteristic velvety thickening and darkening.
So the body is essentially offering us a visual, tactile shortcut to metabolic dysfunction. It's almost screaming, hey, I have too much circulating growth factor.
That's exactly right. It's a very visible marker.
But we need to use an age clue, you mentioned, to guide our further investigation and determine the significance.
Yes, that age clue is absolutely fundamental for diagnosis and deciding what action to take. In younger patients, children, adolescents, young adults, AN is typically benign, and it's overwhelmingly associated with underlying insulin resistance due to conditions like obesity, type 2 diabetes, or polycystic ovary syndrome, PCOS. In these cases, it often coexists with numerous skin tags, eccricordins, especially in the same areas like the neck and armpits.
So AN plus lots of skin tags in a younger person is almost a gold standard marker for insulin resistance.
It's a very strong indicator, yes. Needs metabolic workup.
But if it appears suddenly or for the first time in an older individual without that history, that changes the differential quite dramatically, doesn't it?
That is where the stakes get much higher. If the onset of AN is rapid, if it's very widespread, or if it occurs for the first time in an older adult, particularly someone without obvious signs of obesity or metabolic syndrome, it raises the urgent suspicion of malignancy. Yes. Specifically, we must screen for underlying gastrointestinal GI or genitourinary GU cancers. Gastric adenocarcinoma stomach cancer is the most classically associated malignancy. Malignant AN also tends to be much more extensive, sometimes involving the palms, soles, or even the mucous membranes of the mouth, which you don't typically see in the benign form.
So this duality, usually metabolic disease in the young, but possibly cancer in the older or rapid onset cases, makes AN, as the sources say, an important cutaneous marker of systemic disease. The skin is giving us a viable, nuanced clue about deep internal health, but we have to interpret it in context.
Precisely. Context, especially age and onset, is everything with AN.
Okay, so our bodies use the skin to tell us when we're unwell internally. But sometimes the very medicine we use to help the body creates signature skin issues that require really careful attention. Let's look at Section 4, the impact of medication.
Yes, medications are common culprits for skin reactions. We'll start with a very common issue that often confuses people: the drug-induced phototoxic reaction. This is where a drug essentially acts like a sunlight amplifier. It causes a rash, exaggerated sunburn reaction that can be quite severe, much worse than expected for the amount of sun exposure.
And the mechanism here is key because, as the sources stress, it's a non-immune reaction. It's different from a typical allergy, right? It doesn't require prior sensitization.
Exactly. That's a critical distinction.
Yeah.
It's direct, dose-dependent tissue damage. It's not an allergy involving IgE or T cells. What happens is the drug molecule, let's take a common antibiotic, like doxycycline as an example, absorbs ultraviolet light, usually UVA radiation. This absorption excites the drug molecule.
Okay.
The excited drug then transfers that energy to surrounding oxygen molecules in the skin, forming highly destructive reactive oxygen species, ROS, things like singlet oxygen and free radicals. These ROS then cause direct damage to cell membranes, DNA, and other structures within the skin cells. It's essentially a chemical burn catalyzed by light and amplified by the drug.
The features sound pretty painful. Rapid onset, redness, erythema, swelling, edema, and sometimes even vesicles or bullae, blisters. But what is the critical defining pattern of phototoxicity that helps us identify it?
The absolute definition is its confinement. The reaction is strictly confined to sun-exposed areas. If the area was covered by clothing, a sleeve, a watch band, a collar, the reaction stops precisely at that line. You get these sharp cutoffs.
Like a sunburn, but way worse and faster.
Exactly. And importantly, there is no mucosal involvement. The mouth, the eyes, the genital areas are spared. This lack of mucosal involvement is absolutely crucial because it distinguishes phototoxicity clinically from far more severe, life-threatening, immune-mediated systemic reactions like Stevens-Johnson syndrome, SJS, or toxic epidermal necrolysis, TNN.
That distinction is paramount, especially mentioning SJS10. Just briefly for the listener, why is mucosal involvement in SJS10 so incredibly dangerous? What does that signify?
It signifies a catastrophic systemic immune attack on the entire epithelial lining. In SJS10, the body's immune system mistakenly attacks the skin and the mucous membranes, the lining of the eyes, mouth, throat, airways, gut, genitals. This causes widespread blistering and detachment of the epidermis, often over a huge percentage of the body surface area. It's like a massive body-wide burn from the inside out.
Oh, wow.
This leads to massive fluid and protein loss, high risk of overwhelming sepsis, and severe long-term complications like blindness, esophageal strictures, or permanent organ damage. It's a true dermatologic emergency with high mortality.
Okay, so the fact that phototoxicity is only on the sun-exposed skin with sharp borders and no mucosal trouble confirms it's a localized, direct toxic insult, not that kind of systemic immune collapse.
Precisely. It's bad, but it's contained. Key drug culprits to remember include the tetracycline antibiotics, especially doxycycline and minocycline, diuretics like hydrochlorothiazide, HCTZ, certain NSAIDs like naproxen, antipsychotics like chlorpromazine, and the heart rhythm drug amiodarone. Lots of common meds.
Right. Management then is pretty straightforward. Stop the offending drug if possible and institute strict sun protection hats, clothing, broad-spectrum sunscreen.
Absolutely. Avoidance is key.
Okay, let's move on to another drug reaction that often mimics something common. Drug-induced acne, or perhaps more accurately, steroid-induced folliculitis.
Yes, this is frequently confused with regular acne vulgaris, the kind teenagers often get, but there is one defining feature that really shortcuts the diagnosis.
And that defining feature is the uniformity, the sameness of the eruption.
Exactly. We call it the monomorphic appearance. This acneiform eruption, meaning acne-like, most commonly caused by systemic glucocorticoids, steroids like prednisone, is defined by the fact that all the lesions look the same size and are at the same stage of development. They're usually small, inflammatory red papules or sometimes pustules, and they tend to erupt almost simultaneously, typically on the chest, upper back, shoulders, and sometimes the upper arms.
In contrast, standard acne vulgaris is polymorphic, right? Meaning you see a mix of things: blackheads, whiteheads, comedones, red bumps, papillaries, pus bumps, pustules, deeper nodules, maybe even cysts, all at different stages of development.
That's the key difference. Drug-induced folliculitis characteristically has no comedones, no blackheads or whiteheads, and typically no cysts or nodules. Because it's thought to be primarily an inflammation of the hair follicle driven by the drug's metabolic effects, rather than a primary issue of blocked pores, comedones, standard acne treatments like topical retinoids or benzoyl peroxide are often not very effective.
Oh.
The clinical management pearl is simple. Improvement really only occurs when the offending drug, usually the systemic steroid, is stopped or the dose is significantly tapered.
That makes sense. Treat the cause.
Oh.
Okay, let's shift quickly now to type hypersensitivity, the classic immediate allergic reaction, and then we can look specifically at its most common manifestation on the skin.
Sure. Type hypersensitivity is an IgE-mediated reaction. This means it involves preformed immunoglobulin E antibodies. It's incredibly rapid, occurring literally seconds to minutes upon re-exposure to an allergen the person is already sensitized to. What happens is the allergen could be a food, a drug, an insect sting, cross-links these specific IgE antibodies that are already coating the surface of mast cells and basophils. This cross-linking triggers massive, immediate degranulation of these cells.
And they release.
They release a flood of powerful preformed inflammatory mediators, most famously histamine, but also tryptase, heparin, and others. They also quickly synthesize other mediators like leukotrienes and prostaglandins. This chemical cascade causes the immediate symptoms.
And the clinical spectrum can be quite alarming, ranging from just mild skin reactions all the way to full-blown anaphylaxis.
It certainly can. The range goes from mild localized urticaria, hives, and pruritus, itching, maybe some flushing, all the way up to life-threatening anaphylaxis. Anaphylaxis involves multiple organ systems, typically skin signs, plus respiratory compromise, wheezing, shortness of breath, throat swelling or laryngeal edema, and or circulatory collapse, hypotension, shock.
And the management hinges entirely on where the patient falls on that spectrum. If anaphylaxis is suspected, any respiratory or circulatory signs, what is the absolute priority?
If the patient shows any moderate to severe features, any sign of breathing difficulty, significant angioedema, swelling, especially the face, lips, tongue, or throat, dizziness or hypertension, that is a true medical emergency. Seconds count. The priority is immediate first-line treatment. Intramuscular epinephrine, usually injected into the anterolateral thigh. Epinephrine acts incredibly fast to reverse bronchospasm, raise blood pressure, and reduce swelling. It's life-saving.
And other treatments follow.
Yes, after epinephrine, supportive care is given. This includes H1 and H2 antihistamines to block further histamine effects, and corticosteroids like prednisone or methylprednisolone, primarily to prevent potential late-phase reactions, which can occur hours later, but epi first, always in anaphylaxis.
Okay, that sets up our final point in this section perfectly. Acute urticaria, or hives, which is the most common skin manifestation of this rapid histamine release we see in type I reactions, though it can have other triggers too. How do we define hives clinically and diagnostically? What makes them unique?
The absolute defining time limit, the characteristic feature of acute urticaria, is its transient nature. These are intensely pruritic, very itchy raised, often pink or red wheals, which are areas of localized dermal edema, swelling in the skin. They often have pale centers and red borders, but the key feature is that each individual lesion is incredibly short-lived. A single hive typically appears, maybe grows or changes shape, and then completely disappears without a trace, usually within minutes to hours, and almost always lasting less than 24 hours.
Ah, okay. So even if the person keeps getting new hives popping up elsewhere for days or even weeks, the individual spots themselves come and go very quickly.
Exactly. The eruption as a whole might persist, but the individual components are fleeting.
And that fact that they appear in one spot and vanish rapidly differentiates this rash from almost everything else, right?
Yeah.
Like contact dermatitis, psoriasis, or viral exanthems, where the lesions typically stay put for days or weeks in the same location.
That transience is the undeniable hallmark of a histamine-driven mast cell-mediated eruption like urticaria. It tells you it's likely driven by something causing rapid mediator release. Management for acute urticaria, which is usually self-limited, defined as lasting less than 6 weeks, is primarily focused on controlling the intense itch and blocking the histamine receptors.
So antihistamines.
Yes, primarily second-generation H1 antihistamines like cetirizine, loratadine, or fexofenadine. They are preferred because they cause much less sedation than the older first-generation ones like diphenhydramine. Sometimes higher doses are needed.
Okay, in our final section, we have to return to the most severe physical injury we discussed, burns. But this time, we're focusing on perhaps the most fatal complication following the initial injury and resuscitation: sepsis in severe burns.
Yes, this is a critical topic. Burn wound sepsis is, tragically, the leading cause of mortality in burn patients who survive the initial trauma and fluid resuscitation phase. This is particularly true for those with severe injuries, often defined as burns covering more than 20% of their total body surface area, BSA.
Why does a large burn create such a uniquely dangerous environment for infection to take hold and spread? What makes it so vulnerable?
It creates what is essentially a perfect storm, an almost ideal culture medium for microbes. The burn wound itself is composed of a vascular tissue, meaning there's no blood flow to deliver immune cells or antibiotics effectively. It's also incredibly protein-rich, full of denatured proteins from the damaged tissue, which microbes love to feed on. And it consists of necrotic tissue, the eschar, or dead skin, which shields bacteria.
And the patient's overall state.
On top of the local wound factors, the patient is profoundly immunologically compromised. The massive trauma of the burn triggers a huge systemic inflammatory response. But paradoxically, this also leads to immune suppression, making them highly susceptible to infection. This trifecta of vascular, protein-rich, necrotic tissue plus immunosuppression creates an ideal, protected growth medium.
It sounds like a fortress for bacteria. And our sources show a fairly predictable progression of the types of pathogens we see related to the timing of the infection, don't they?
They do, and this is important for guiding empiric antibiotic choices. We see a clear shift based on the number of days post-injury. Early infection, meaning typically within the first 5 days after the burn, is usually caused by gram-positive organisms. Primarily Staphylococcus aureus, including MRSA or Streptococcus species. These often originate from the patient's own remaining skin flora or mucous membranes.
The gram-positives early on. And what happens is the hospital stay lengthens, the eschar persists, and the immune system remains suppressed.
Then we see the shift. Late infection, usually developing more than 5 days post-burn, shifts dramatically towards gram-negative organisms. These are often highly virulent and multi-drug resistant strains, particularly Pseudomonas aeruginosa, but also others like Acinetobacter or Klebsiella. And we also frequently see fungi, especially Candida species, emerge as late pathogens.
And where do these later bugs come from?
These late-arriving pathogens often originate from the hospital environment itself, contaminated equipment, water sources, or transmission between patients. The change in pathogen type over time means clinicians must remain highly vigilant and be ready to adjust their prophylactic measures and treatment approach, potentially broadening antibiotic coverage as time progresses.
Okay, so knowing the timing helps predict the bug. Now, what are the critical warning signs we need to recognize immediately, both signs locally within the wound itself and systemically that signal the devastating onset of sepsis?
Recognizing sepsis early in burn patients can be tricky because they are already in a hypermetabolic state with inflammation. But there are key signs. Locally, sometimes the very first sign can be a subtle but critical change in the appearance or behavior of the burn wound itself. Look for progression of depth. A partial thickness burn might suddenly appear to deepen into a full thickness necrosis.
Okay.
Or you might see a previously viable skin graft starting to lift off, develop dark spots, or be lost entirely. Or maybe the surrounding unburned skin develops cellulitis. Any deterioration in the wound is a red flag.
And systemically, what tells us the infection has broken containment and is now overwhelming the body.
Systemically, the signs of sepsis are numerous, and critically, some of them run contrary to what you might typically expect, like just a high fever.
Let's detail those specific systemic indicators because, as you said, some of them are counterintuitive, especially regarding temperature.
Right. While hyperthermia, a fever over 39 degrees Celsius, can occur, a burn patient is already in a hypermetabolic state, so some fever might be baseline. The really critical flag for overwhelming decompensating sepsis is actually hypothermia, a core temperature falling below 36.5 degrees Celsius, about 97.7 F. This indicates the body's thermoregulatory and compensatory mechanisms are failing, and the infection is rampant. It's a very ominous sign.
Hypothermia is a sign of severe sepsis in a burn patient. Got it. What else?
Other key indicators of systemic collapse include sustained tachycardia, a persistently high heart rate, often above baseline for that patient, increased tachypnea, rapid breathing rate, and sudden hypotension, low blood pressure or needing more fluid suppressors to maintain pressure. And often confusion or altered mental status is an early sign that perfusion or oxygenation is failing.
And the lab abnormalities. Those are equally important pieces of the puzzle, signaling this systemic crisis.
Yes, absolutely. We look for key lab abnormalities that scream sepsis in this context. Thrombocytopenia, a significant drop in the platelet count, is a major red flag. It can indicate disseminated intravascular coagulation, DIC, or bone marrow suppression from the overwhelming infection. Equally important is new or persistent hyperglycemia, high blood sugar levels. Burn patients are often hyperglycemic due to the stress hormones, but worsening hyperglycemia, especially if it becomes resistant to standard insulin doses, is part of the body's stressed hypermetabolic response, but also signals overwhelming physiological stress and carries a poor prognosis.
Interesting. High sugar is a danger sign.
Yes. And finally, oliguria, a significant drop in urine output, signals poor kidney perfusion and is often an early sign of impending multi-organ failure.
So just to synthesize that, if the burn wound itself is worsening, and the patient becomes hypotensive, maybe confused, tachycardic, tachymic, has dropping platelets or refractory high blood sugar, and potentially is hypothermic instead of febrile, then we are in a true septic crisis.
That's the picture. That combination demands immediate action, obtaining blood and wound cultures, aggressive intravenous fluid resuscitation, and the prompt initiation of broad-spectrum intravenous antibiotics, usually tailored to cover both gram-positives and gram-negatives, especially Pseudomonas, depending on the timing and local resistance patterns. It is truly a race against time to control the infection and support organ function. Hashtag outro. So if we look back across all 5 sections today, the key insight really is unwavering, isn't it? The pattern is the shortcut to understanding. The skin is not just a covering, it is a rapid, comprehensive, and importantly, non-invasive map of both internal physiological processes and external challenges. In every single case we discussed, from the subtle sparing of flexural creases in an immersion burn to the unmistakable velvety texture of Acanthosis nigricans, and even the strict 24-hour transience of an individual hive in acute urticaria, careful observation of the specific pattern unlocks a diagnosis or at least points you strongly in the right direction.
Yeah, absolutely. We saw how a seemingly simple rash or a specific type of blister or a burn pattern tells a deep, often profound story about environmental exposure or underlying metabolism, maybe medication toxicity, or sadly, even intentional harm. The ultimate lesson here for any learner, I think, whether you're in medicine or frankly in any field dealing with complex information, is that careful, disciplined observation of these defined patterns, whether you're looking at a biological system or data in general, is the absolute best defense against information overload. It's what allows you really to cut through the noise and recognize what truly matters, what needs action.
Well said. Pattern recognition is key.
So here's a final thought for you, the listener, to chew on. We established today that blistering specifically on sun-exposed hands, that Porphyria cutanea tarda, PCT, links directly, in many cases, to the chronic systemic inflammation caused by hepatitis C. It's a really powerful, somewhat counterintuitive connection, where an external trigger, the sun, unmasks a deep internal viral issue affecting the liver and metabolism. So if sun-exposed blistering can be a sign of internal hepatic or metabolic trouble, What other common everyday environmental exposures, things like friction or pressure or cold, or maybe even certain dietary components, what other exposures might we be overlooking that could serve as similar signposts, unmasking underlying chronic systemic illness? Something to maybe observe and think about as you go about your day.